it's not on. Is it? Oh, okay.
All right. Thanks for bearing with us for a moment while we work through the audio visual. Well, good morning again. Thanks for joining us for Grand Rounds this morning, and thanks for joining us for the month of January. As a preview, today we're going to be having Dr. Jennifer Spicer talking to us about learner motivation. Next week is clinical case review with Dr. Elena Lebduska. That is Zoom only, so there's not an in-person option next week for clinical case review with Dr. Lebduska. And then the third week of the month, we will have both in-person and Zoom viewing options. And that will be a talk on updates in contraception with Dr. Apurva Ram. So today, we're, again, really excited to Sorry, we had an echo for a moment, but we're still excited to have Dr. Jennifer Spicer join us today to talk about lighting the inner drive, how everyday teaching choices shape learner motivation. Dr. Spicer is the Vice Chair for Education here in the Department of Medicine, having joined the university back in August. She did her undergrad at University of Georgia Medical School at Emory, where she also did residency and fellowship. She has a master's both in public health as well as a master's in health professions education. In terms of her interests clinically, HIV medicine, including HIV primary care, as well as from an education perspective, interests include coaching, feedback, and the science of learning, how we can apply that to improve learning environments with personal interests. For those who are here in person, if you have questions as we go, please raise your hand. I'll circulate with the microphone so you can ask them and people attending by Zoom can hear. And if you're attending via Zoom, please go ahead and type your questions into the chat and I can ask Dr. Spicer.
Great, thank you. So part of the reason I'm really excited to be here is I've been trying to meet people. It's hard coming from another institution where I was for 18 years and then coming in brand new and not knowing a lot of people. So please feel free to reach out anytime if there are things related to education that you would like to discuss. So today, this is actually a new talk that I developed. I'm always looking for feedback when I develop something new. So I will have an opportunity at the end for you to give feedback with some kind of targeted questions. So think about that as I'm going throughout this talk, if you have ideas about how to make it better. But what really drove wanting to speak about this has really been something that I feel like has been discussed over the past couple of years a lot since the COVID pandemic. And that is really thinking about learner motivation. And so I'm not sure if any of you have, oh, this was working before, but now it's not. Yes, I am.
On the wrong screen. Try now.
Give us 1 second. Perfect. So I don't know if any of you have listened to this podcast series, but I feel like this was a really hot topic back in 2024, which was really talking about changes in medical education and medical training and some discussions around kind of evolving cultural norms surrounding work. This was by Lisa Rosenbaum with the New England Journal of Medicine. She actually has a series out right now on primary care that I haven't listened to quite yet, but I imagine is quite good based off of my experience with this. And this really created a lot of discussion at educational circles, and she was actually the speaker at a lot of educational conferences after this to talk about how she was gathering perspectives from both learners and from teachers to think about, you know, what is this kind of cultural change? But this really hasn't been isolated to discussions in medicine. In 2022, towards the tail end of the pandemic, there was this new term, quiet quitting, that became really popular in cultural, in the wider culture, talking about people just, you know, kind of being done with doing extra things at work. And this was staying within the boundaries of your job, really creating boundaries with your personal life. And I feel like this term ended up being associated a lot actually with Gen Z and then brought in a lot of kind of our perceptions about generational norms, which is a talk for another day. thinking about generations, because I think that there are some things that that I've thought about a lot with sociology and how we think about generations. But this has also been in medical education, as we talked about. And there are articles on this thinking about what this means for medical school as people talk about people not coming to lecture, being in the classroom, which, to be honest, has been going on for decades, really isn't anything new. But I think reinvigorated some of these discussions about what our environments look like. And I think a lot of times when we talk about this, we focus on the individual and we focus on the learner. But what we know from a science and motivation standpoint is that this is actually about the environment. So this is about the work environment, this is about the learning environment, and this is about what we do as supervisors and teachers that can influence some of this motivation. And so I think what I want to focus on today is what can we do as teachers, as educators, and supervisors to think about how we can alter learner motivation. And if you aren't working directly with learners, the same thing applies to a lot of other venues. This applies to really work in general, and organizational psychology is where a lot of this originally comes from. But also, honestly, in our personal lives, a lot of these same things are in the parenting literature as well. So before I get started, I want you to think about someone you've worked with. It could be a supervisor, a teacher, a coach, in a time that you really felt motivated. Or maybe somebody who you worked with where you felt really unmotivated working with them. And think a little bit about why you felt that way. Like, what did they do? So I'm going to give you just a second to reflect. So as I'm going through this discussion today, I want you to think about what things we're talking about today may have applied to that situation, a time where you felt really motivated or maybe unmotivated, and things that led to that. So here's my outline today. So first, I'm going to talk a little bit about like the science of motivation, just a little bit of background on motivational theory. And then I'm going to spend most of the time talking about these three components of motivation theory: competence, relatedness, and autonomy, and what we can do as educators in these areas to really influence learner motivation. So let's start with a little bit of background. So when we think about learning, we know that learning process is mapped to three different dimensions. And so as you're thinking about the science of learning and ways that we can improve learning, you can think about one of these three dimensions. So the first is kind of cognitive, and this is really what we often term as the science of learning. Things like spaced repetition, how we process information, providing concrete examples. So this is really that act of learning that we talk about. This is honestly one of my favorite topics, but something that I'm not going to touch on as much today. Then we think about the affective component, and this is really that motivating factor, like why we learn or why we want to learn, that emotional aspect of it. And then finally is that metacognitive aspect, or how we're regulating our own learning and really being able to recognize what we do need to learn, how we need to adjust our learning processes. And so today, I'm just going to focus on this middle part, really that emotional aspect of learning. So with motivation, there's kind of a spectrum. Okay, so a spectrum from someone who is completely amotivated. This may be the person who, you kind of see not really paying attention, is maybe what that looks like, doing their own thing. You perceive that they might be bored with what's going on. Then we have someone who is extrinsically motivated. And I think that we have all experienced this, probably both ourselves and working with learners. This is the learner who is really focused on kind of performing, right? That performance goal of, I really want to get a good grade. What's going to be on the test? Let me focus on kind of those types of things. So they're doing things because of either external rewards or punishments. And then we have intrinsic motivation, which is really people doing something because they want to, either it is personally fulfilling, they find joy in it, or they really like the process of learning. So it's a little bit more complicated than this. And I'm not going to spend a lot of time because this is a lot of like really kind of deep theory on motivation. But I think what's important to recognize is within extrinsic motivation, there's a spectrum. And the reason this is important is I think that we can all agree that there are lots of things that we will never be intrinsically motivated to do, right? There are things that like are not joyful to us. One of those may be documenting, right, in the medical record. We're never going to find like intrinsic motivation to do that, but we can work to find things that make it a little bit more fulfilling and create environment. So what I mean by that is within extrinsic motivation, there are sometimes things that we do because it aligns with our values. So I don't love documenting, but I know that if I do a really good job on that and it's helping patient care and it's helping those other providers or helps me in the future, that that's helpful, right? So we can still move things along the spectrum. So what we're going to talk about today is kind of the theory of how can we move people along the spectrum from either amotivation or extrinsic motivation to be more intrinsically motivated. And this process is called internalization. So internalizing kind of those norms and behaviors into ourselves. And the theory that I'm going to talk about just briefly and base this on is self-determination theory. This is something that was developed back in the 80s by sociologists, as a lot of our kind of organizational psychology is. And they talk about components that help us move people towards intrinsic motivation. This is honestly my favorite med ed theory. And I think a lot of things, as you think about it, maybe come down to some of these three components we're going to talk about. But you may be asking, like, why do we care? Like, as long as people are doing the thing, do we care if they're intrinsically motivated or extrinsically motivated? And the answer is yes, because we do know that intrinsic motivation leads to better outcomes. This has been shown in a wide variety of literature in different professions. We know that it increases attendance and engagement. It actually improves learning. So instead of kind of surface learning that people don't remember, they really engage in deep learning. It helps with creativity. It helps with people persisting, like really trying to work to solve problems instead of giving up early. It results in intent to continue. And I would say this is also intent to continue in your job. So this is an important piece as we think about a lot of people experiencing kind of burnout within their jobs. We know it improves well-being and just in general improves positive emotions towards what we're doing and towards work. So what we're going to talk about are these kind of three components that we can affect to promote internalization of motivation. We're going to talk about how we can help build competence. So this is helping people feel more capable or effective at their role. If we can do that, people will be more intrinsically motivated. If we can foster relatedness, so this is helping people feel really connected to others, cared for, and feel significant. And then if we can work to promote autonomy, really having people have the perception of having control or choice over things that they do. So this is going to be kind of the three sections of the talk. But before I start, I just want to give a disclaimer that, you know, like a lot of things we think about in medical education, some of these things are going to seem really, really obvious. You're going to be like, yes, I know this, I've heard this. My goal is really to be focusing on the how and why this works, and to really help that when you do have that situation where you're teaching and you're really struggling to motivate a learner, that this allows you to really then sit back and reflect on these three things and understand what you might be able to adjust in your own teaching. And so I'm going to try to give as many concrete examples as I can. I'm going to try to give outpatient examples as much as I can, since I know that that's the context that you're working in. But some of this may seem really obvious. And I feel like a good med ed talk is actually when people leave and feel that there wasn't a ton of jargon. So that's my goal, but I am going to infiltrate some theories for those who are interested to give a little bit of background. All right, so let's talk about competence. So this is really helping people feel effective and capable at their jobs. So we're going to talk about 3 different kind of med-ed concepts in here. We're going to talk about deliberate practice, which is really kind of the process by which we gain expertise. We're going to talk about the zone of proximal development, which is helping learners identify that right challenge, that correct goal that's going to help them. And then we're going to talk about growth mindset, or how we foster that psychological state that helps people work within an area that may be difficult for them and helps them be okay with failure. So let's start with deliberate practice. Not sure how many of you have read the book Peak, or seen Anders Ericsson talk, or read any of his work, but he really is like the person who studies expertise. So he spent a lot of time learning from like famous chess players, famous musicians, people who are really experts in their field across professions. And what he learned from this is that there are certain ways that we develop expertise. So as we know, the more you work in something, the more experience you gain, you're going to improve, right? And we see that that accelerates during training. You can see that steep slope. But what happens after, when you're like no longer in training, is a couple different things. One is maybe you keep repeating the same thing, you're still gaining experience, but you actually stop developing better performance, because what you're engaging in is just habitual repetition, like doing the same thing mindlessly, but not really thinking deeply about it. And so you're going to plateau. And that may be fine, but that is something that you no longer derive quite as much joy from doing that work. Or you could maybe have your skills decay because you have limited practice. This would be like me with thoracenteses. Haven't done one since training. You don't want me to do one on you, right? Very limited practice in that. Or you can actually continue to accelerate over time. And these are the people we really see as experts. There's like expert clinicians that you go to and you feel like can always kind of work through a problem. What they're engaging in is something called deliberate practice, okay? So we're going to talk about what deliberate practice is. It's actually really simple. There are 3 requirements, okay? One is that you have a really defined and specific goal that you are working on actively and thinking about as you're doing things. The second is that you have repeated practice, so repeated reps doing that. And then the third is that you have immediate detailed feedback in some mechanism. That could be from a coach, but that could also be from other areas. So let's use tennis as an example. I previously played a lot of tennis, not quite so much anymore, but when I used to play a lot, one of my goals was I really want to improve my serve, right? Okay, so that's a goal I'm working on, but that's really not specific enough. If you work with a really good coach, what they're going to do is they're going to watch you try to serve, and then they're going to say, your problem is your ball toss. You are not tossing the ball high enough, and that's what we need to work on. Okay, so what we're going to do is we're going to sit here, and you're not going to just keep serving. You are just going to toss the ball. And I'm going to give you feedback on this as we're doing it. So toss the ball, toss it a little higher, a little bit more to the left, toss it up higher again. Okay, now let's like go back and do the components. For those of you who were musicians, right? Same thing. You work on that really difficult passage that you're struggling with in something before you go back and play that whole section. And so the key here is really that really specific defined goal. So let's talk about what this could look like in medical practice. So let's say you're working with a learner and they come in and they say, I want to work on my presentations. You say, great. Okay, let's see what part of the presentation you need to work on. I think you really need to work on the HPI, okay? We really need to get that story down. And where you're really struggling is that you really aren't telling a good chronological story. So we're going to work on, I want you to start from when the person last felt well and tell it in order. Okay, we're going to do this repeatedly. You're going to keep doing this week. This is the one thing we're going to focus on all week for you. And then maybe there are other things they need to work on, like figuring out which pertinent positives and negatives to include. Or maybe they need to be faster. And your goal is really to get them faster on their HPI so that we can move through the day. And so again, finding that specific goal that's going to help your learner and then doing that repeatedly. With the physical exam, again, this is something that I feel like a lot of residents would come to me for, and I'd say, okay, we can work on your physical exam, but let's pick a specific part. So is it the cardiac exam? Is it that you were able to perform a complete cardiac exam and know all the steps and can do that on everybody? Or you want to be able to auscultate accurately and identify murmurs. You want to use the exam to tell you what the patient has and use it more diagnostically rather than just doing the steps. So the key here is that you have to pick something where people are going to have repeated practice and can get immediate detailed feedback. And so sometimes I have learners come to me with goals that we're not going to be able to do over that period of time. And so that's when you may have to change the goal if you really want to engage in deliberate practice. All right, so let's talk about how you select that goal using the zone of proximal development to think about that right challenge. So this is a theory, thinking about like, what is the optimal place for us to work within? Okay, so we all have our comfort zone, and those are things that we can do on our own, kind of feels like really easy. We don't have to think about much. The zone of proximal development are things you can do with support. So you might not be able to do it totally on your own. Maybe you need to look at a checklist while you're doing it. You need somebody watching and talking through the steps. And then these are my own terms, the danger zone, are things that someone cannot do even with support, right? Like I can't do an appendectomy, not a surgeon. So what are those things and how can we find someone's zone of proximal development to help them work? So this is what I do with people at the beginning of the rotation, is I try to help them identify within their goal, their zone of proximal development. So what this may look like is maybe you have a learner with you who their comfort zone, they're a beginning of the year med student, they can really gather a history, they can do that really well. But where they're really struggling is they can't take that history and synthesize it to then develop a differential diagnosis. So you decide that that is kind of their zone of proximal development, and that's your goal you're going to work on. But if they can't develop a differential, like there's no reason for them to start formulating a plan yet, right? Because like that's not going to be helpful. They can't even get to the differential diagnosis, okay? Or if you teach procedures, you know, a resident may be able to kind of list the steps of a procedure. They know like how to do a lumbar puncture, how to do an arthrocentesis. And maybe they're really good at performing it in that moment with your help, right? You tell them the steps, you remind them, you kind of like help them angle things. But they probably aren't people who can perform it in an emergent situation yet, right? Like that's not the place that you want them practicing or doing it. And so finding this zone of proximal development with our learners will help establish the right goal for them. So I think an important part about this is it's really effortful to work in this zone of proximal development because you're not doing automated tasks, you're working really hard. So there was a study looking at trainees and looking at kind of how they did things during their day at work, okay? And what they saw is they would do something hard and then they would go and work within their comfort zone and then go back and do something hard and then work within their comfort zone on throughout the day. And I think this is important because we have to remember that that is really tiring for people. And so that's something that we might not do with every patient we have with somebody, that we may need to limit it. And we may need to also ask where learners are just kind of in their general just feeling, right? Like, did they just come off a hard rotation and they're really tired? And maybe this isn't the day for them to really be working in that zone. So what do learners think about this? This was actually a study that I'll come back to a little bit later, talking about learners working actually in clinics and a longitudinal placement. And learners talked about how there were things that facilitated their learning. There were kind of a couple different things. So one was that they had to have the right mindset, which we're going to talk about in just a second. They need to be kind of willing to go and try it. But that having people who really push them into that deep water, push them to do things slightly beyond their capability was really helpful. And the important thing with that, though, is they had to have a safety net. They had to have somebody who was supporting them and had that right level of autonomy for them so that it felt safe. So let's talk about the last piece of competence, that mindset piece of willing to go out and try it. Okay, so growth mindset, I feel like has been in the popular kind of discussion for the past decade or so. And really, Carol Dweck is the one who wrote this book on it that talked about two different states, a fixed mindset and a growth mindset. And I think the important piece about these is that you don't either have a fixed mindset or a growth mindset. Changes over time. Like you may have a fixed mindset and think like, man, I'm not athletic, right? Like I could never be athletic, but you may have a growth mindset in other ways. So what do these mean? Well, it's really our beliefs about intelligence. It's, do we think that things can't change? Okay, so a fixed mindset is when we think like, I am not athletic, nor could I ever be athletic, no matter how hard I tried, versus a growth mindset is where we can develop it. And this is important because you'll see that this goes kind of towards some of the intrinsic and extrinsic motivation. So people with the fixed mindset are really focused on looking smart and focused on their performance, kind of similar to what we talked about with extrinsic motivation. Whereas people with a growth mindset are there to learn and really focused on just improving and getting better. So this impacts how they approach challenges. People with a fixed mindset like don't like challenges because that makes them feel like they aren't good, right? That like is a reflection on them and they really give up early. Whereas those with a growth mindset see a challenge as an opportunity and really embrace it. People with a fixed mindset think if they have to try really hard, that means that they're not good. And then this can really make them feel, just discourage them from everything they're doing. And then how they respond to feedback is important. So people with a fixed mindset really don't like feedback. They, because they don't see that as an opportunity for growth. They see that as a reflection of who they are. Okay. And then it also impacts how they view others. So if they have a fixed mindset, when they see others succeeding, they really think that that's a threat to them. Whereas people with a growth mindset really kind of celebrate and see that as a source of inspiration. And so sometimes you can see behaviors in your learners that may show that they are exhibiting a fixed mindset to something versus a growth mindset. And there are ways that we can kind of change maybe their mindset around what they're doing. So how can we promote a growth mindset when we're teaching? So I think the most important thing is in the beginning, when you're working with someone new, even if it's just for a day, setting an expectation. And this can take one sentence. I tell people that they're with me so they can get better. And if they were already as good as they needed to be, then they wouldn't be in training. Okay. So I say, like, what's one goal we're going to work on? I use all the deliberate practice, zone of proximal development. And then I tell them, like, I'm going to push you like to the limits of your knowledge because that's what's going to help you get better at this. During the middle, I think it's also role modeling our own vulnerabilities. It helps other people feel okay with not knowing things. Okay. So, for example, I often share with people, hey, this case is really challenging to me. I don't have much experience like seeing this. Here's what I learned when I read about it last night. Instead of like pretending like I went in and like knew everything about it when I had looked at up to date right before, or sharing my struggles with a case or a patient that we're seeing. And then finally, at the end, when you're giving feedback, there's a lot of data about how you give feedback and how that impacts people's mindset. So not telling them, hey, you're really good at X, because that's like commenting on their character in some way. But I noticed that you worked really hard on your communication skills. And this is a specific example of a way you did a really good job in this. And here's like the next area of growth for you. So seeing it more as kind of a learning process. So, phrases that I found helpful in thinking about a struggling learner, because people are still going to have moments where they go back into a fixed mindset, is, like, you're supposed to feel this way, like, normalize it. Like, this is supposed to feel hard. Like, that means you're learning, and this is a really challenging case. Or, your goal isn't to be perfect today. That was a good presentation. There are ways to make it better. But just like, remember, you don't have to be perfect at this. We're going to keep working on it. When providing feedback, thinking about normalizing the struggles they're having, like, hey, we all went through this. I remember when I went through this and had these struggles. Or when you're giving feedback about something that is maybe like constructive feedback, something they really need to work on, instead of saying you're not good at this, saying something like, look, this is your growth edge. Like, your growth edge now is learning how to lead a team. You're doing a great job at taking care of patients and doing things independently, but your growth edge is really learning this bit of autonomy and how to help your learners move forward and lead the team and step back. Okay, so how do we build competence? Establishing that reach goal. So thinking about your learner, like assessing them on day one and either having them pick it or maybe helping refine it. Making sure that you're providing specific frequent feedback on that one tiny thing. So just focus on one tiny thing with people and work on that during the week. And then normalize that, like, this is hard, and debriefing failures, because that will help people get into that growth mindset that it's okay to be failing. And then make sure with feedback, focusing on like what they've been working on, what you noticed, and what's their next step, rather than saying you were a good communicator or you have really great medical knowledge. Okay. So I spent a little bit more time on building competence because I think this is a really important piece and something we're doing every day. But now I want to move a little bit to relatedness, which I think is something that most of us have a lot of experience in. And so I just want to highlight a couple key pieces that are really important that I've thought about as I've been reading over time in this topic. So we're going to talk about in versus out groups. This is very much based in sociology, about how we form connections with people. We're going to talk about psychological safety and then legitimate peripheral participation. Okay, so in versus out groups. So we all know it's really important to get to know our learners, right? I mean, that connection piece, we all remember mentors that we worked with that we still think about today that really helped our practice. But it's really hard. Like when we're really busy and somebody comes in, a little bit late, we have a busy schedule, it's busy on service. Sometimes it's hard to take that moment to really do that intro piece if you already have a patient waiting or you already have 3 consults. And so one thing that I've tried to do is, even when it's really busy, making sure I set aside just a little bit of time to humanize the team. Okay, so I'm going to talk about this a little bit about what I do on inpatient, but I do the same thing in the outpatient clinic when I'm working one-on-one. And I want to shout out Dr. Kimberly Manning, who's been one of my mentors for a long time, because the way I did introductions was different until I actually heard her give this earlier this year and talked about her intro style. So I think a lot of our intros is like, tell me where you're from, tell me like, where'd you go to school? Where'd you go to medical school? And all those types of things. We'll talk about how that can kind of make people feel either in group or out group and how that may adversely impact people. And so what I really love about these intros is it's really focused on whatever the person wants to talk about. So what's your name? How do you pronounce it? And what do you prefer to be called? Okay. Something that makes you excited or happy. or something that makes you nervous or fearful. And she talks about how this is really important because of that vulnerability piece. And I think this is probably more important in the inpatient setting when you have a big team and you're trying to get everybody comfortable together. I will be honest, I do not use these two phrases all the time, but there are times that I do if I can tell that my team kind of needs it. Something you should know about me that makes working with me easier. Okay, so that's something everybody shares. And then something personal about yourself. And what I like about this last one is it's not like a forced question, like, tell me your favorite food or something like that that makes people nervous. It's just like whatever personal thing you want to tell me about yourself. But this helps us kind of form connections with each other. And this is important because we know that we are social creatures and we like to form connections with people. And in sociology, we talk about in groups and how forming connections is we identify in some way with someone else. We have similarities. And a lot of this was kind of based off of things like, gender, race, nationality, and all of these things, but also profession or specialty. And so I think for, we always get really excited, like on rounds for me, somebody says they want to go into ID. That's not a common thing that a lot of people mention. And so that always makes me really excited during intros. I kind of feel this connection with someone else, but that can also kind of make maybe other people feel excluded in some ways too. And so being careful if you're in a group setting. But even things like what schools people went to, hobbies. And so we try to form connections, but when we're doing that in a group, it can sometimes make other people feel like outsiders if you form too strong a connection with one person and not others. Because if you have an in group, that means there's also out groups or people that you don't identify with. And I think there's a lot of things that we do in medicine that unintentionally outgroup learners. Okay. So I'm going to use some examples of things that, I have been guilty of in the past saying and how this could kind of make people feel kind of like they're part of an out group, right? So, I don't understand why they won't do surgery on that patient. Like it's so hard to convince them, to remove the graft, to tap the joint, whatever we may talk about. But if we have a learner who wants to do surgery or has, a family member in surgery, that may make them feel kind of excluded. Same thing like, oh, I can't believe the nurse did XYZ, right? Why didn't the outside hospital recognize that this patient had X? Or, people just aren't interested in learning anymore, like students, Gen Z, whatever you want to say, like. And so all of these things can make people feel excluded. I think we know this, but I can say I'm definitely guilty of sometimes saying some of these things, either where people may be able to hear or just venting during the day and forming connections through venting. But I think being thoughtful about what we may be saying that makes our learners feel kind of excluded. And so one thing we often talk about is the culture question as a way to form connections. Okay. So this, when we're working in groups. And so I've thought a lot about this because I hate these kinds of questions a lot of times. It makes me like super nervous to think about like, what great show am I going to share that like, what do other people think and things like that. And so trying to think about how you can replace this with broader questions. So like maybe not like what show have you watched recently, but like what's something that you've seen or listened to recently that you really enjoyed? Or instead of like, what's your favorite Thanksgiving food? Maybe people don't like celebrate Thanksgiving or, there are other things with it. Like, what's something you're looking forward to during the break? Or instead of, what's your favorite winter outdoor activity? Like where people are like, oh man, I don't really spend a lot of time outdoors. I'm not very athletic. I feel kind of weird with this group. What do you like doing during this season? Okay, so psychological safety is probably the most important piece of this. And Amy Edmondson is the one who came up with this. She wrote the book, The Fearless Organization, talking about in the business world. And really, this concept is how safe it feels to take a risk and be wrong. What's the temperature of the learning environment? So there's lots of literature on this. And I think that the key here is from a learner perspective. This is what helps people feel like they can learn and not be performative. So exactly that growth mindset we're trying to get people into, psychological safety is a really key cornerstone of it. And so in her book, Amy Edmondson talks about how leaders can promote psychological safety when we're working with people. And she talks about 3 points: setting the stage, inviting participation, and responding productively. Okay. So I am actually going to use an article, and you will see some familiar names here, that asks students kind of like, what makes you feel safe? And then they categorized it into these 3 areas, and you can see how it comes through. So setting the stage is really someone being like eager and having a positive attitude, and having that leader who cares about the team. They're excited to be there, they're excited you're there, and they set expectations. So like what they're looking for, and they say like, I care about your learning. My goal is for you to learn. Okay, so these are kind of some of the points that were really important that came out of this. 2 is that inviting participation. And I think this is easy when you're working one-on-one, a little bit more difficult when you're working in a group, but making sure to emphasize that like, we're all here together to do this, and that we are still learning as attendings is an important piece of it, because then people feel like what they're adding is helpful. It's not just that they're telling you what you already know. And then responding productively, because people are going to say things that are wrong. And so how you respond to that matters and changes whether they're going to talk again. So do you kind of like respect other inputs, and not just like respect them, but when people say something, do you say, that's a great idea. In this case, maybe that's not the right thing, or here's something that I think is more likely, but I love the way you're thinking about that. Tell me how you got there, and explaining why you might be going a different route. And so I think that these are some of the keys that came out of it. That enthusiasm piece is probably one of the most important, and it's hard to do all the time. Like, I'm not always enthusiastic at work. There's sometimes I'm just really tired, but sometimes I need to set that aside and just like, when the learner's there, be enthusiastic. Inviting everybody to share things and sharing our own gaps and mistakes. And then responding in a way, again, that reinforces what people are doing. And this article on intellectual streaking is a really interesting, like 2-page read that just talks about the importance of us showing our vulnerabilities. Because when we show mistakes we've made, things we've gotten wrong, that we don't know what's going on, it makes other people feel more comfortable. And so instead of that like all-knowing expert clinician that I feel like many of us became used to seeing and we're trying to be, remembering that that vulnerability piece is actually going to help our learners probably more than anything else. All right, so legitimate peripheral participation. So I think this one is really simple in medicine. So the concept of this is people are coming into a community, and the more they participate, the more they feel part of that community. So the more they're able to do things that are authentic pieces of work and that matter and are significant. So examples of this in the outpatient setting from that article I mentioned earlier, students talked about like, it sounds silly, but like typing up patient notes or calling the patient like makes me feel important and that I'm doing things that are helpful. Having the administrative staff like know us and acknowledge us, and like sometimes I'm filling out paperwork for them, again, is like, I feel like part of the team. And the things that made them not feel part of the team is like, I felt like I was in the way. I was in the kitchen. There wasn't a spot for me, right? And they just felt like they weren't part of the team. And in the inpatient setting, or when residents are working in subspecialties, again, there are parts of it where they just feel being an autonomous practitioner, being a team member, really having other people on the team recognize them were an important piece of it. I won't go into much detail here because I know this isn't the space that you're working in. So how can we foster relatedness? So again, humanizing as we talked about, setting aside like 2 minutes for that intro, avoiding the negative comments, which is obvious, but I think something that we are all guilty of. At least I know I am. Making sure that we explicitly say that we want their input, and then sharing when we're uncertain, and making sure that they are full members of the team. So I'm going to kind of go through this full member of the team piece with the autonomy very briefly. Okay, so I'm going to talk about supported autonomy versus supervision because I think we often conflate these terms. And these are really distinct terms. So often we think about autonomy as meaning somebody's independent and they don't have supervision. But autonomy is actually this internal sense of, do I have choice and control? Like, am I able to do things? Independence is like you don't have any support around you. And supervision is how much somebody has external oversight. So there are lots of people who have lots of external oversight. I'm sure you remember the attendings who were like looking at every piece of the chart, but they still let people have autonomy and make decisions. And so they talk about these attending typologies that I think will sound very familiar to illustrate how these are very different. So attendings who are very supervision heavy, very hands-on, that micromanager, you don't have any autonomy, right? You can't make any choice. They change every little thing. You have the absentee attending. So this is the one who, like, you know, they're hands off, they're not there, but then they're doing things behind the scenes or like making phone calls or coming in and changing the plan even though they're not there. The colleague, so this is somebody who's hands off, like, I trust you, I'll let you do whatever you want. They're providing a lot of autonomy, but they're maybe not supervising as well as they should, maybe not paying attention to things in the chart and things get missed. And this can be really stressful for trainees. And then the coach. So this is somebody who's like paying attention to everything in the chart and what's going on, but also letting people make decisions. And so this is really where we want to be. And so residents reflecting on autonomy, I love this paper that talks about their views of what autonomy looks like. And I think the thing that comes out is that what they respect the most are people who say the evidence behind what they're doing and don't just do something because it's their personal preference. And so this is something we all have preferences about how we practice, and in trying to make sure that we give a reason. And sometimes my reason is I'm just uncomfortable because X happened. And this is kind of my preference, but what you're saying isn't wrong. But like, this is a time for XYZ reason that like, I really think we need to do this. And so they talk about these attending behaviors that can promote and undermine autonomy. Okay, so they talk about learners leading patient care. So this means full patient ownership, right? They're the ones responding to things in the chart. They're the ones calling the patient. Challenging the learner to make the decisions, collaborative management, and then making sure that you give them space to work. I feel like this is more a challenge inpatient where people can kind of work in the workroom sometimes, which can be really problematic. It makes people feel that they don't have independence. And then things that undermine autonomy is if you've already made a decision and you don't really listen to the learner's input and just say, okay, great plan, here's what we're going to do, which I feel like is a risk I've had in the outpatient setting because things have to move quickly. And so really taking that time to think about the learner and letting them think about the care plan. And then again, that not leaving the work area that I mentioned. And so when residents aren't getting enough autonomy, how they react depends on the safety, like that psychological safety of the environment. And so I start every rotation by telling people like, hey, my goal is to give you autonomy. I want feedback if I'm not. And so if people feel safe, they will then negotiate if they have too much or too little if you ask them. If it's unsafe and they have too much autonomy, they'll get help from peers. But I think the danger is when people become a passive observer. And so if you notice a learner being a passive observer, that may be a sign that they have too little autonomy, but also maybe don't feel like they can speak up. Okay, so managing failure. I'm going to skip this reflection. But what I want to think about you to just briefly think about is times you may have let a learner fail. I feel like this is a little harder in the outpatient setting because we have less time to watch people. But there's some really interesting literature about failure and how it's helpful for learning if it's in a supported environment. And so letting people fail by establishing the expectation that failure is normal. And then attendings often decide this based off of patient and learner factors and the team and, what's going to be safe. But the key is we often don't debrief it with people after. And so that's something that can be really helpful if people fail. You want to help them debrief the emotions. And so examples of failures that we think about may even just be some of these things like you let someone lead a goals of care discussion or counsel somebody on tobacco cessation. And it's not going to go well, but you want the learner to experience that and fail and then debrief it afterwards. And so learners felt failure was helpful if it was psychologically safe, which we've talked about. They knew the person was doing it because they had good intent. They were doing it to help someone's learning, and then they debriefed it. So again, this talking about creating a psychologically safe environment that made it feel safe to fail to learn. Okay, so for promoting autonomy, I think encouraging learners to make all those decisions as much as possible. And I think in the outpatient setting, this is very plausible as well. When somebody has something you're not going to do, instead of saying, no, but here's what we're going to do, saying, yes, that's a great thought. And here is what I think really helps. Only changing the plan if there's like a real, true evidence-based reason and sharing why that is. And then maybe consider allowing people to fail. Okay, so we talked about self-determination theory in these three components, but I think one important key, maybe you're doing things and it's not working with a learner, is to remember that this can only work after people's basic needs are fulfilled. And so we know what has to happen first is people have to be in a good space. They have to be healthy. They have to not be tired, and we know that in medical training, often people are all of those things. They have to feel secure and stable, and then they can do all these other things, right? And so we have to make sure that if somebody's not doing well, we explore if there could be reasons why before continuing to try things. So as I mentioned, this can apply to a lot of other settings. For example, there is a lot of evidence that with raising children, that if you provide them with more autonomy and choices, that they are less likely to do drugs or do other things. So it's a pretty interesting literature base. And so if any of this interests you, these are books that I've mentioned that I think are really helpful on the topics. And there's some research resources as well. And so to close, again, we talked about competence and these three ways to kind of create goals and a training plan for people. We talked about how we can connect with people and make sure they feel safe in the environment, and then making sure that people have autonomy and support. So I'm going to leave for a second this feedback code. Sorry, this is one for me with some specific questions about how to get this better. And then I will show the regular Grand Rounds code in a second. This one is purely free text. I appreciate any and all feedback. I know that there are some things I definitely need to cut for the future to make this slightly shorter. And so if you have ideas, let me know. And I will leave this up during questions. Thank you.
Dr. Spicer, thank you for really that invigorating talk there. People attending by Zoom, please enter questions in the chat and I can read them out loud. People in person, please raise your hand and I'll walk over to you with the microphone. I'll start out with a question of my own, which is related to sort of integrating a few of these aspects of competence and growth mindset, really focusing on effort
Mhm.
and developing mastery rather than just results, along with psychological safety and how we integrate that with the fact that a lot of times we have to do assessments. And so, how do we do this in a way that is, as educators and leaders, that's promoting these safe environments, but also not blindsiding
Mhm.
learners when it comes to assessments if they're not at that top level?
Yeah, I think that's a great question. And I think this is actually why a lot of the literature has talked about like grades versus no grades and what does that mean. But this is where setting expectations is probably the most important. And then giving people frequent feedback on whether or not they're meeting expectations. And so if we have grades that are very much based on objective behaviors that we're watching, and it's really clear like what meets each level for the grade, I think it's then really easy to say, look, you are really good at developing a differential diagnosis. To get to that next step, here's what you need to do. Let's work on this together. And so, as much as we have objective information about what grades kind of apply to, the more it helps. And this is part of the reason that sometimes normative grading can be problematic, right? Because if you're going to have a certain percentage A, B, that like directly goes against this concept of fixed and growth mindset. And so, having objectives that everybody can reach and then explicitly talking about those, I think is the best way to be able to get there.
Question I have is, I think you could think of examples for residents we work with, medical students we work with. Sometimes the things that we're doing, the clinical case, the care is not aligned with the student's long-term goals. Maybe they're thinking of doing fellowship. Maybe they're
Mhm.
thinking of doing a different specialty altogether. And so ways that you think we can help transition them from that extrinsic to more intrinsic
Mhm.
motivation when we encounter that scenario.
Yeah. So I always try to think of goals in kind of like two different ways. One is what people have to do to get through to like make a good grade, right? So part of it is, let's say somebody's on medicine rotation, there's certain competencies that you have to get to that point. And so sometimes I explicitly say these things and help them get to that point. But what I try to do more often is think about how it applies to their future practice and weave it in there. And so, even if you just weave one thing in a day about that, so maybe it's like blood pressure control and somebody who's going into surgery or anesthesia or something like that, and you acknowledge, like, hey, I know that you're planning to go into X. And one thing that's going to be really important for you to know is kind of blood pressure control. So, like, let's talk about how you would do this in X circumstance and directly apply it to their future career. I found that that engages people. And even if you just do that once a day with people, they're more likely to then care about some of the other things because you've acknowledged them and formed that connection with them and shown that you like care about what they value. And so then they become more engaged in what you're going to do.
Last question we'll have today from the chat. Thanks. This was really thought provoking. How can you suggest or perhaps support us in your role that we incorporate some of these practices in the outpatient setting when we don't have extra time for working with students?
Yeah. No, I think that that's always a really challenging piece. And I think thinking about those like micro things to do. And so, for example, what I do in clinic when I have a student can be really stressful and really feels like it lengthens my day sometimes. But I try to make sure that first time I'm working with them, it's like very brief intro. And I have them pick one thing they're working on. And then I have like a reading list of things that if I'm busy, that they can like look at and think about. So I did HIV primary care, it was like the HIV guidelines. And after we saw a patient, I'd be like, I need you to go look this up and I need you to come back to me because I need this answer to take care of this patient. So I would send them to do some of the work, including some of the calling patients or things like that, that actually shortened my day. And then I would work on one thing with them. So that may be antiretrovirals. I'd be like, every patient, what we're going to talk about is their antiretroviral regimen and side effects. Like that's your learning today. That's what we're going to talk about. Or you're going to do the cardiac exam on every patient because you're in your cardiology block. We're going to do that. That's the piece that you're doing on every patient. So I think thinking about those, like, again, those micro skills that you can do throughout the day on one piece, which I think makes it like less effortful for us as teachers to then think about if we're just focusing on one thing.
Spicer, Dr. Spicer, thank you again for joining us and giving us this wonderful talk. For everyone in the division, next week, again, it will be clinical case review, and so that's Zoom only, clinical case review with Dr. Obduska. Thanks. Have a great day.